My name is Michael Mark, and I'm the AARC Associate Executive Director for Distance and E-Learning. I'd like to welcome you to today's webcast on the Strategic National Stockpile, What Respiratory Therapists Need to Know. The AARC is committed to providing you with current information on topics of interest through the convenience of webcasting, and we thank you for participating. Oops, my images aren't going. Upon completion of this AARC webcast, participants will be able to describe the SNS ventilators and capabilities, explain how ventilators are stored and maintained. They will be able to to describe aerosol producing procedures and describe techniques to reduce the risk of transmission, and describe the appropriate use and care of circuits and humidifiers in a mass casualty situation, and explain the clinical and monitoring implications of using filters in various parts of the circuit. It is my pleasure to introduce today's speaker, Eileen Malatino and Richard Branson. Eileen is a registered nurse and is employed as a health scientist with the Strategic National Stockpile Program at the Centers for Disease Control and Prevention. Rich Branson is a registered respiratory therapist and the Associate Professor of Surgery in Division of Trauma and Critical Care Department of Surgery at the University of Cincinnati Medical Center in Cincinnati, Ohio. Eileen will begin the program today by discussing ventilators in the Strategic National Stockpile Program. Eileen, welcome to the program.
Thank you very much. I just had to click my lock talk on there, and I'm going to click on to my next slide, my first slide. But I want to thank you, Michael, for having me, and I want to thank the American Association for Respiratory Care for inviting me to do this presentation. I hope the information that I'm going to give you today will help you understand a little bit about what the Strategic National Stockpile has in the way of ventilators and the corresponding ancillary equipment that we have available. Now, throughout the presentation, I'm going to call it the SNS because that's easier to say than Strategic National Stockpile. The presentation that I'm doing is not meant to be a how to operate the ventilators, but rather to let you know what we have and how it will arrive. In some of the slides, I will provide some basic features of the ventilators, but the technical aspects of the ventilators are contained in the manuals. And I do have the manuals in electronic format, and my last slide will have my contact information. And if you would like those manuals or if you have any questions later, certainly feel free to email me. My first slide here, initial ventilator selection. What I want to do is just give you a little bit of information about the history of how the ventilators were selected. Back in 2000 and then again in 2002, subject matter experts were asked to develop criteria for a mechanical ventilator for use in mass casualty situations. And the first phase for this group was to develop those qualitative and quantitative selection criteria for the stockpile to consider when developing a request for proposal for vendors and manufacturers. And the second part, or the second phase, was a formal review of those who submitted proposals. And as part of that phase two, the panel convened and they met and they reviewed the responses that they got from the manufacturers and the producers, and they also actually examined some of the actual devices or ventilators. Members of the panel included experts in the field of medicine, as well as persons from the national societies and individual leaders who had an interest in that field. The recommendations the panel came up with were divided into three areas, as you can see on the slide, and those were clinical technical, operational, and logistical. Now, some of the capabilities desired you can see listed here, but they're not limited to just these, but some of them they would like for them to have PEEP, no pending obsolescence, extended battery life, audible alarms, technical support 24/7, which was very important. They were latex-free, portable, And of course, for the SNS, storage was a huge issue. The funding provided for the purchase of approximately 2,000 of each type of ventilator. So we got money that allowed us to buy 2,000 of each for a total of 4,000. Due to production issues, the ventilators did not arrive at the same time. As a matter of fact, the Univent Eagle 754 started arriving in the fall of 2001, and the Puritan Bennett LP10 began arriving in somewhere around the spring of the spring of 2003. And as you can see, a bullet under the LP10 states that as of today, November the 1st, 2006, the LP10 will no longer be manufactured. The SNS actually learned in August of this year via a letter from Puritan Bennett that they will cease manufacture and worldwide sales of the LP10. Because of the number of vents that we do have in the SNS from Puritan Bennett, they have said that they will try to provide parts and service for the next 5 years. So currently, issues are being worked through our logistics folks and our contract personnel to try to make sure that that happens, you know, at which point, if they have to be phased out, then at least we will have care up until that point. I'll mention briefly about new ventilator acquisition in my last slide. Pictured here are the 2 ventilators currently stockpiled by the SNS. The one on the left is the Puritan Bennett LP10, the one that is being phased out by them, or that they are no longer producing. And the one on the right is the Impact Univent Eagle 754. I just wanted to mention here that there is a process of requesting these ventilators, and this process will be through the same sort of channels set up for requesting any of the SNS assets, including managed inventory or what we call our 12-hour push packages. That means that Health and Human Services and CDC will usually make the decision to deploy these ventilators, and in some cases, HHS may say how many vents can be sent at any one time. This, of course, will depend in part on the event and how many states are affected. Additionally, the ventilators are considered recoverable assets for the SNS, and the SNS will recover them when they are no longer needed by the state. The end users, such as a hospital, will be responsible for ensuring that these ventilators are cleaned before the SNS recovers them. Most of the ancillary equipment used with the ventilators is disposable, so it's mainly the ventilators and the cords and the kitting cases that are recovered. This slide just shows some of the specifications of the ventilators. In the first row, you can see the weight of the ventilators alone and then how much they weigh kitted. How we kit the vents will be shown in a later slide, but basically a kit is a hard case that contains the ventilators and the ancillary equipment or supplies. As you can see, the Univent weighs 13 pounds alone and 32 pounds kitted. Likewise, the LP10 is 35 pounds alone and 61 pounds kitted. The second row is just the dimensions of each ventilator alone, and then also right underneath that are the ventilator case dimensions. Some people like to know that information. That's just why I put it in there, especially if you're looking at storage issues while you're waiting to use them. The third row compares the battery life of the 2 vents on either room air or external gas. And as you can see, the LP10 cannot extend its battery life by the use of external gases like the Univent can. I believe that there are external battery adapters available from the manufacturers, but these are not provided by the SNS. So that will not be an item that will be coming with these vents. Now, in this slide is a list of what is included in each of the cases other than the ventilator. You can see that a check mark indicates that the item is included in the case, and that in the Univent, the PEEP and the O2 enrichment option is built in, so therefore that will not be included in that kit. So when the ventilator kits arrive, they will contain most of the items you see and that you will need to get started. So basically it's like a computer that comes and you just plug and play, that sort of thing. And a limited amount of the ancillary items in this slide are also maintained by the SNS in our managed inventory, and I will talk about that in another slide later. Now, this is just an example, and I've got several more pictures, but this is just an example of an open case with the ventilator and some of the ancillary equipment inside. And I'm going to show you some more pictures now following here so you can actually see a little bit better what is in those kits. In this picture, I actually removed some of the items from the case so you can see them better. Note up at the top it says there is an instruction video, and I've sort of got some little arrows going to where that is. There is also an operation manual included. There are also note that there are pediatric and adult circuits included. So each of these is set up for one patient, but if you have to switch it off to another patient, if that person is a child, then you've certainly got some of your equipment there that you need. Also included are your air and your oxygen hoses, as well as AC power adapters and the 12 VDC power cable, which is an adapter that plugs into, I guess, like a car cigarette outlet or power outlets, I think they're now called in most vehicles. But you can see all of this stuff sort of fits into the case. I've got a couple of more pictures here to show you. What I wanted to point out here is that the Univent has a canvas carrying case and a strap that so that you can carry it over your shoulder if needed, and it's pretty handy. The P10 does not have the cloth case or a strap because it's just too heavy and too bulky to try to carry it over your shoulder. This is just another picture of 3 of the ancillary items found in the Univent kit. Now remember, the 2 kits will be different depending on what's built in and what's not and what has to be added. The PEEP is built in, of course, on the Univent, so it will not be in the case, but of course it will be provided in the LP10. So you can see here a bacterial filter, the HME, and an O2 reservoir kit. If anyone has any questions about these as I'm going through, please feel free to ask me the question.
But, now, Eileen, I had one. This is Mike.
Okay.
Earlier on, you made mention about how very much important technical backup was. I assume you were referring to, I think, respiratory therapists in that particular situation, weren't you?
Actually, what I was talking about was if there happened to be some particular things that came up that you needed tech support from the company, such as Impact or Puritan Bennett. One of the things that we had talked with them about was, did they have tech support 24/7? And in the manuals, they do have 800 numbers where somebody could reach them if they needed to. If there was something in particular, the machine just wasn't working and they had to figure out what was going on. Did that answer your question?
Yeah. Has there been any discussion, since the LP10 is not necessarily going to be available, and you said they're going to try to support it for 5 years. What's the position CDC on that?
Well, I mean, we will continue. We'll have to arrange a contract with them, and they will continue to provide service and support and parts and whatever else we need for the next 5 years, at which point, and I'm going to talk later a little bit about the fact that we'll be getting new ventilators later on, and I'll discuss that, and that'll be close to one of the last slides that I talk about. But it is something that we're concerned about, because that tech support is very important, because sometimes it may be going to a place where they really haven't ever seen this ventilator or had a chance to touch it or see it or something like that.
Your answer is very timely. In one of our questions, Joe D says, what is the replacement plan for the LP10s when parts and service become scarce? Well, I'll leave this. Everybody can read his other comment, but I think you're going to address that.
Yeah, and I'll talk a little bit about it. I can't go into a lot of detail about that, but just suffice it to say that there will be replacement ventilators, and a lot of them coming in at some point in time. They're still working that out, and I'll talk about that when I discuss very briefly about pandemic flu, which is something all near and dear to our hearts here at CDC. Anyway, was there another question, I think, or was that it?
No, go ahead. There are some questions coming in, but I think you're going to cover them, Eileen, so just go ahead and
okay.
do the presentation.
All right. If these questions are not answered in the presentation, please ask me at the end, and I will do that. Pictured here, I wanted to show you. I don't know if any of you know what the Strategic National Stockpile's 12-hour push packages look like. This is one of the smaller containers. And this is the way in which the ventilators are stored in our warehouses and the way that they will be shipped to wherever they're going, say, such as a hospital. And for those of you who have heard of the SNS 12-hour push packages, this picture is what the small container looks like. However, you all must be aware that the ventilators are not stored in the 12-hour push packages, but are stored in our managed inventory. Now, when we say 12-hour push packages, that means that there is certain equipment, medicines, and emergency supplies that will arrive within 12 hours. The ventilators, depending on where they're coming from and where they're going, may be able to arrive in that time, but we don't guarantee that. This is like any of our other managed inventory. There can't be a guaranteed time on when they arrive, but generally we can get them very quickly. They're very quickly. The ventilators will be delivered to a site designated by a state, and then the ventilators will be removed from the containers, say at the hospital, and then these containers will come back to the SNS. These are recoverable containers. This slide just shows the univents inside the container, but the LP10s are also packaged this way. These containers can hold 28 univents or 10 LP10s, and they're on wheels, so they roll very easily. So say, for instance, if you wanted 56 ventilators, you would get 2 of these containers. They would be wheeled into a room and then taken out as you needed them. And that way, if you didn't, at least you know where they are when they get there. The ventilators are signed for by the state or by the end user, and we will recover these ventilators, and I will talk a little bit more about that later on. Now, ventilator management is something that is done here at the stockpile. The storage and maintenance of the ventilators is performed by our SNS biotech staff. These biotech staff maintain most of the functions that you see listed here, such as the periodic charging of the batteries. So, say for instance, the LP10s need charging, recharging every month, and the 754s every 4 months. And they have them configured in these cases so that they have one plug, and they plug it in, and it charges that whole container. So it's pretty cool the way they do this. You have to imagine that with 4,000 ventilators, it takes a lot of time to go around and plug in every one of these. So they've figured out a method for taking care of that. The ventilators are also rotated to the vendors on a scheduled basis, and that way their service technicians, in other words, the vendors, the ones who manufactured them, can make sure that the ventilators are in tip-top shape. So they will look at the batteries, make sure that the ventilators are running well, and they're doing all the things that they're supposed to be doing when you receive them. And I'm telling you all of this just so you're aware of how much effort goes into maintaining the 4,000 ventilators. It's a lot of work, and it takes up a lot of time. The last bullet mentions cleaning and recovery of the ventilators following use. And although these biotechs will be part of the recovery process, it's expected that our end users of the ventilators, the hospitals or whoever, will ensure that the vents are decontaminated before our techs retrieve them. In other words, we don't want our techs or anyone else who is recovering our equipment to become contaminated or exposed to something, say for instance if they were on plague patients or patients with the flu or whatever. We just want to make sure that our staff is protected when they come to pick these up. So we say that the ventilators will fall under, say, your cleaning protocol, whatever it is you have in, or your decontamination protocol that you might have at a particular hospital. Okay, this slide here is just showing the disposable items that come in the kits and that will not be recovered by the SNS. So you can see the adult and the pediatric circuits are disposable. Even if we have not used one of those circuits, we will not recover those. We will only be bringing back the durable medical equipment. We will not recover the bacterial filters, the intake filters, the HMEs, the PEEP, or the O2 reservoirs and enrichment kits. And as I mentioned before, the SNS keeps a limited supply of these additional items that can be requested as needed Now, the picture that you're seeing there on the right shows an example of an SNS managed inventory warehouse. So it's a warehouse set up sort of similar to this, where the ancillary supplies are kept, as well as those containers, those small containers that you saw that held the ventilators. They will all be stored in these nice, neat warehouses. Additional ancillary equipment can also be purchased and shipped from the vendor. So say, for instance, there was a particular item that the vendor had given us, or we had purchased from the vendor. If we needed additional supplies, certainly we would go to that vendor and purchase additional supplies as needed. The end users should anticipate their needs early on to ensure that equipment arrives on time, because we don't send, the kits come with all of this stuff in it, but as you run out of that stuff, if you're going to need more, then that's where I'm talking about the end user should anticipate their need to request more of this stuff, because we will send whatever they ask, and as we need more, we'll try to order more along the way. Some of this you all may already have in your stock, but we try to anticipate some of the needs that you all will have during an event. Now I'm going to talk just briefly here about future ventilator purchases. This is my final slide, and what is mentioned here is one of the current issues that Health and Human Services and CDC are looking at, and that is ventilators for pandemic flu. And although the ventilators could certainly be available for other uses as authorized by HHS, their concern is for the large number of persons that may need ventilation assistance during a pandemic flu outbreak. There is currently a group of experts looking into these ventilators. The type of ventilators and how many they're going to purchase is currently being looked at by this group of subject matter experts. And as that information becomes available, it will certainly be made available to the states and other end users or interested parties. I hope the information that I've given you today is giving you a little bit better idea of the ventilators that the SNS has available at this time, and also some of the ancillary equipment that will come. As situations arise and as the SNS mission expands, we will expand our capabilities to provide needed life-saving supplies. My contact information is on the slide if you would like to receive an electronic version of the manuals, or if you think of questions later on that you would like to ask me. And I also put the website for the Strategic National Stockpile. You can go there and you can click on that, and if you scroll down on that website, you actually can see what an entire push package looks like. But remember what I said, the ventilators are part of managed inventory and will not come in the push package. It is a separate ordered item, and so I want to make that very, very clear. And if we want to go to some questions, other than that, I'm going to turn this back to Michael, and we can go with the questions, any questions that may have come up.
Eileen, beautiful presentation. Certainly there were some questions I do want to bring up. A couple of them, Mike M. says, will one vent be for primary deployment over the other?
No, one won't be the primary deployment over the other. We have had exercises in the past where a state may have requested a particular ventilator simply because they have, in fact, stockpiled the particular circuits or some particular equipment that goes with one of those ventilators. We will send out the ventilators. Actually, say, for instance, it was someplace in the Northwest where the ventilators were needed. In that case, we may deploy ventilators that might be closest to that site. So it just depends. And as the ventilators are used up, say we run out of LP10s, then we're going to ship, you're not going to be able to get anything from us but impacts. But we do not send one over the other, no, although we have that request. Sorry.
Eileen, that's fine. How quickly, once notification has been made, how quickly will the ventilators be deployed?
Well, once we have the approval from HHS and CDC to ship the ventilators, they will go out right away. And to give you a time frame, I can't give you a time frame. I can just say that they will get there very quickly. I know we've done exercises where we've deployed ventilators, and it can be anywhere from 5 hours up to 36 hours. But generally, they're already packed in these kits, and as you can see, all we have to do is load them on a truck or a plane, and they will be there within a certain time frame. It's certainly not going to be days to weeks, okay? It'll be hours is what it will be.
Oh, there's a good question. It says, will the state, HHS, or DHS make the decision who gets the ventilators first? How, in your understanding, how will that happen?
Okay. Generally, I think it depends on the event. So if we're looking at pandemic flu across the United States, we don't make those decisions here at the stockpile. Those are decisions that will be made depending on the event and how many states are affected. So if all the states are affected, it's going to be up to HHS to say, you know what, this is the plan, this is how many ventilators you get New York, this is how many you get California, that sort of thing. And it's going to sort of be, as it happens, who needs them at the time. But I have a feeling that they've got some sort of plan that they're looking at as far as that. But a lot of this, you have to be very flexible. So we can't say who's going to get it first. They're going to make those decisions.
I'm seeing a whole raft of questions, and I really think that you're honing in on. Clearly, the audience is wondering, okay, who's going to decide? Is it HHS or DHS from the state level to the federal level? And then who's going to get it first and that sort of thing. So I think you've really answered those questions well. It says here, how will the push pack get to the hospitals? And I'm assuming,
you cut out on me there for a while, so I missed like about 2 seconds worth of speaking. But basically, in a pandemic situation or a mass casualty situation that's occurring across the nation, it's going to be at a higher level of decision, and it'll be HHS and CDC who will be making those decisions on where they go, who gets them, and how many you get. Basically, that's all I can say about that.
The last question I think we'll field here is the question: how will the pushback get to the hospitals?
Okay.
I assume meaning from when it lands via plane. How will it get to the hospital from there?
Okay. First of all, let me just clarify here. A push pack, I don't know, if you're talking about the 12-hour push package, that is totally separate from the ventilators. If you were talking about how will the push packages get to the hospitals, generally they'll probably be trucked in. Say if they come in at an airport, then they'll be trucked in by officials, and that'll all be arranged by the states. And that's between the Strategic National Stockpile and the state. And we have consultants who do work with the states on getting stuff where it needs to go. If you're talking about a 12-hour push package and you're talking about the stuff that comes in that, which is not ventilators, then there is a particular site where it goes and it's stored and then it's picked up as it's needed and moved to the sites where it is needed.
I think that's an excellent answer, Eileen, and I do want to appreciate, again, the AARC's, or I do want to express the AARC's appreciation in you doing this. And what I think we'll do now in order to really round out and top off this excellent presentation is turn it over to Rich Branson and let him do his thing. And if we have any more questions at the end or whatnot, we'll make sure that you get them at another point.
Okay, I just noticed that Joe D. has a question there that really needs to be answered, and I can do that at the end if you like.
Oh, no, let's do it right now.
Okay, his question was, if a disaster occurs, what is the process that respiratory therapist managers would initiate to obtain ventilators from the SNS? It is not a hospital or a respiratory person or a physician's job to request the ventilators. This is a process that usually starts at a higher level, such as a disaster is declared within the state or a state of an emergency, and then the governor or his designee will then request up the chain to HHS that they need help. And at that point, HHS or NCDC will make the decision to deploy whatever it is that that state has requested. So understand that it does not come from an individual at a hospital or, a particular person, a respiratory therapist or anybody else. It does come from a higher level after a disaster has been declared or a state of an emergency or an emergency has been declared. So just wanted to clarify that.
Well, not only has Jody had a series of excellent questions, but you certainly had the answers, Eileen. What I'm going to do now is turn it over to Rich. Give us a second here to make sure Rich is all ready to go, which it looks like he is. And Eileen, if you take your lock talk off, I'll be chatting with you and Rich after the presentation.
Okay, Michael.
Go ahead, Rich.
I was asked to kind of talk about some of the practical stuff for respiratory therapists. So I think there are some things that we all need to consider, which include how to use these ventilators, what principles to use, and importantly, because SNS is going to send us circuits and HMEs, and we probably all actually have quite a bit of stock of these devices at our hospitals, so we don't know how long they'll last, and we need to use them judiciously. This idea of avoiding aerosolizing procedures I want to talk about because it was important in the SARS epidemic. And then I don't have enough time to go into all of it, and this is not really my area of expertise, but everybody has to really be familiar with their personal protective equipment. And I have to tell you that CDC has an excellent, on their website that Eileen's directing you to, CDC has an excellent group of media and posters you can print out and educational systems for helping you understand personal protective equipment, not only what kinds you need, but how to use them. So Eileen's already showed you the stockpile ventilators, so I want to tell you a little bit more about them. Both of them are volume ventilators. Neither one of them will do pressure control or pressure support. Now the LP10 is capable of setting a pressure limit, but it's a mechanical pop-off, so the ventilator still delivers the breath at the same flow rate and inspiratory time. The LP10 does not have a blunder, so it will be difficult to give high FiO2s. There is a low-flow oxygen inlet, and I'm going to show you pictures of the two types. And you don't have control of PEEP, so you'll have to use an external PEEP valve, and then it will become important to set the sensitivity at such a point so the patient can trigger the ventilator. The Impact 754 will take a high-pressure oxygen inlet or low-pressure oxygen, so you can deliver 100% oxygen if you have 50 psi gas. And one of the issues that I get into with the 754 is that it only has a maximum flow rate of 60 liters per minute. And so if you have a patient who's very actively breathing, it may be that the work of breathing could be very high. And so I suspect that we will ventilate most people in assist control and probably give them reasonable amounts of sedation. The other thing is that I wanted to talk about is when the 754 was designed, it wasn't meant, there was no such thing as closed circuit suction catheters. And the 754 has a particular system safety that if for some reason the pressure in the circuit falls below 10 centimeters of water pressure, negative, for longer than 2 seconds, the machine will turn itself off. And the reason is the inlet for the compressor is the same size as the outlet for the circuit. And there was concern that, since this is a ventilator used in the military, that if this were used in a stressful situation in the dark, that if somebody hooked it onto the wrong connector, you end up drawing gas out of the lungs. So what does this mean to the therapist? And any of you who've worked with this device or some of the military people know, sometimes you can get somebody who's very aggressively breathing during suctioning, and while they're taking in deep breaths and you're sucking the gas out, you'll meet that criteria of minus 10 centimeters of water pressure and the ventilator will turn off. It's not broken. All you have to do is click the off switch off and then turn it back on and it'll start to work again. But that does happen. It's not a common occurrence, but it certainly does happen. It has to be something respiratory therapists recognize when it does happen. It does alarm to let you know. With the LP series, you do get an external PEEP valve. And remember, this is like in the old days. The LP10 isn't capable of automatically knowing what the PEEP is and keeping the sensitivity the same. So you literally will put the PEEP valve on and then increase the sensitivity, make it more sensitive with the sensitivity setting until you see it start to auto-trigger. And then when you see it start to auto-trigger, then you'll turn it back to the lowest sensitivity setting that allows the patient to trigger to the ventilator, but precludes auto-triggering. And for some of you who've been around as long as I have, that's the way we used to do things with the MA1 in particular. Right? And the other thing that I think is very important for therapists, especially if you haven't used these ventilators for a while, if you set the PEEP, you have to set the low alarm level above the PEEP level, or you're going to end up with this constant low pressure alarm, which in the stressful situations, which we expect, is going to be kind of painful to listen to on a regular basis. This is a picture just showing you the use of a vital signs PEEP valve on the expiratory valve of the circuit, and you see both circuits for the LP10 and the impact are the same. The old style mushroom, although it's just a disc exhalation valve, and the green tubing there for monitoring airway pressure. So once you set that PEEP valve in line, you do have to reset the sensitivity in order for the patient to trigger it effectively. The other issue about the LP10 is the bleed-in. It comes with two oxygen systems. One of the systems is shown in the picture here. The other one's just an elbow that goes on the outlet of the ventilator, and that's what you use if you want to have FiO2s below 40%. And realize that for any given oxygen flow, the FiO2 you deliver to the patient will depend on the respiratory rate and the tidal volume, so the total minute ventilation. And also remember that if you're bleeding gas into the inspiratory limb of the circuit, you'll also be augmenting tidal volume, so that's something you want to be aware of. For higher FiO2s, there's this system here, and you see what you're seeing is the back of the ventilator, the LP10, where the inlet filter is. And this system comes with the device in the, from the stockpile, and you have a reservoir bag, and you see where the oxygen connects. And then it uses that bag as well as that tubing to fill with oxygen. And then when the piston draws in gas to deliver the next breath, it will draw in gas from that bag. And just to the left of the oxygen inlet there, kind of looks like a valve that you might turn. That's actually it's kind of an anti-asphyxia valve for the piston. If the piston draws in and the bag goes flat because the O2 flow is not high enough, it just draws in more room air, which decreases your FiO2. But it clearly is important to look at understanding these systems, because just about every kind of scenario we envision for being mass casualty respiratory failure, the most likely one, I suppose, is avian flu. Avian flu is a severe form of respiratory failure. Anthrax is a severe form of respiratory failure. SARS is a severe form of respiratory failure. So we're going to have adequate levels of PEEP, control of tidal volume, and delivery of adequate FiO2s. The 754 can do the same thing the LP10 does, which is you can have the air bleed in, or it will work with high pressure air and oxygen, which you kind of see here in the system, that it will take both 50 psi or 50 psi oxygen. If you don't have the air, the internal compressor will run by itself, and if you have neither, the internal compressor will run, and then you'll have to add oxygen to the circuit. Very similar to the way you do the LP10. And just to give you an idea, these pictures are a little small, that the outlets on the top of the 754 include the circuit connections, which you see, and they're color-coded to make it easier. The green goes to the green, and the white goes to the white. The patient outlet, in that patient outlet is also where the anti-asphyxia valve is, in case you lose total gas source supply or electricity. But on either side, you see the high pressure and low pressure air oxygen, or high pressure air and high pressure oxygen inlets. And the ventilator recognizes when it gets 50 psi air and shuts off the compressor automatically, which significantly lengthens the battery life. And this is just a picture up close. So you see the exhalation valve and the transducer are color-coded. And this is one where we have high pressure oxygen and high pressure air connected to the ventilator. And if you look kind of closely, you see the outlet from the ventilator down on at about 7 o'clock. That what looks like something laying up against the wall. That's like a one-way valve on the old-fashioned non-rebreathing masks. And that one-way valve closes during positive pressure ventilation. If the patient breathes in, that's where the room air comes in from. So again, I want to remind you about this. If the airway pressure is below 10 for 2 seconds, the ventilator will turn off, that this is a safety measure, and all you have to do is turn the switch to off and back on again, and it can occur with closed circuit suctioning. And if you're going to use closed circuit suction, which I assume most of us will use, it's probably a good idea, especially if there's a contagion that's involved. If you switch the ventilator in the SIMV mode, what ends up happening is the low airway pressure triggers the demand valve, and it's less likely that the ventilator will shut off. So that's a little secret if you happen to be using the device. I think another really important issue, especially for pediatrics, we keep talking about these mass casualty scenarios as if everybody is going to be an adult, and clearly that will not be the case. But this is the circuit that comes from the Strategic National Stockpile, and you can see that there's that flex tube and elbow that goes to the patient connection, the endotracheal tube. Adds about 30 milliliters of dead space, which is going to be no big deal in your adult patients, but in pediatrics it is going to be a problem, and you should be aware of that and be ready to remove that and use another adapter to connect directly to the endotracheal tube to remove that dead space. It will be a real problem for controlling CO2 when you start getting at low tidal volumes, those less than about 200 milliliters. Again, that will be for either ventilator. This is if this ever happens, and I guess we all hope it doesn't. It's kind of like being in the military. You train for war all day and pray for peace all night. So I'm glad that SNS and CDC have been so proactive in getting all this stuff together. But if this does happen, what we have to do is, this is not the time to say, well, I only like pressure control, and I only like IMD, and I only like APRV, or I can't do this without PRVC. If you have lots of patients and not enough equipment, it also means you won't have enough staff. So the simplest ways of treating the patients will be the best, and that will include putting people on assist control in volume control ventilation with normal IA ratios and starting at a PEEP of 5. Everybody should be familiar with calculating predicted body weight now on patients based on height. Remember, the major determinant of lung volume is height, not weight, and this is the equations that were used in the ARDSNet trial. We probably ought to start everybody at 6 to 8 mLs per kilo and maintain the plateau pressure less than 30 if that's possible. IA ratio should be at the most 1:1, and in fact the impact won't even go to an IA ratio greater than 1:1. Patients should be adequately sedated. Again, not enough staff, not enough people to keep an eye on things. This is not the time to let people be wide awake. We'll do spontaneous breathing trials either in CPAP mode or just from T-pieces like we used to do in order to determine who needs to be weaned. And something that I won't talk about but we'll see more of is you'll have to triage the ventilators themselves, but also the ventilator capabilities to meet patients. So if you got 30 Puritan Bennett 840s at your hospital, and all of a sudden you have 30 new people who need to be ventilated, and then you get some ventilators from the stockpile, you kind of look around and say, well, that guy's on pressure support of 8 and a PEEP of 5. He could probably go on the LP10, and my new patient with anthrax, inhalational anthrax, and severe hemorrhagic pulmonary edema is going to go to the 840. So it will be a case of right ventilator for the right patient, obviously within reason. And there will be, what they like to say in mass casualty issues is that everybody will get care. It's just that some of that care will be palliative care, not dedicated towards actually treating the patient's illness but making them comfortable. And that's something we're going to have to kind of come to grips with, I think, as a society. Humidification. You can't mechanically ventilate somebody without humidifying the air. Obviously, HMEs are going to be a lot easier, and they're going to be more available as well. You will triage your current active systems the same way you probably do now, and give HMEs to the patients without the secretions and the bloody secretions. Think about in ARDS, if you start using lower tidal volumes, you can use the pediatric HMEs for adults, which is something a lot of people actually do in their operating room and something we can think about in the ICU. Circuit changes, I think everybody's pretty comfortable now that you change the circuit in between patients. So just use the same circuit on the same patient until it's over with and then throw it away. There remains no good evidence that you can reuse circuits on the same patients just because you use a filter in the airway, and I would not recommend that, because even if you could keep the inside clean, the outside's going to be dirty, and you may cross-contaminate people. Another issue about dead space. This is kind of our typical setup at my hospital, and you can see that with an HME and a flexible catheter mount and the closed circuit suction system, that you can pretty quickly get near 100 milliliters of dead space. So think about these things when you're triaging your patients and you're ventilating them. That dead space is always an issue and will always be an enemy with low tidal volume ventilation in pediatrics whenever you have hypercarbia. And I just wanted to show you that, and this isn't my opinion, this is from a paper in intensive care medicine showing you that for given patients with ARDS, these are patients who are all being supported using the technique of permissive hypercapnia, that just removing the HME itself significantly reduces the PCO2, and that's something that we ought to talk about. And this is work from Dean Hess showing a meta-analysis of ventilator circuit changes, and I don't think there's any reason to argue about the fact that we only need to change circuits between patients. The routine changing of circuits is a thing of the past. And this is just more data looking at observational studies, and essentially what you're looking at is a decision tree, and anytime something falls away from the center, like the diamond at the bottom, which is all the studies put together, it means that less frequent changes are probably okay. I did want to show you this because people have shown, manufacturers say change your HME every 24 hours. All these people listed here and all these papers show that you can actually use it for longer than that, and some of these studies say 48 hours, as you can see, some of them 4 days, and some of them as long as 7 days. So I think it's probably very practical that, and here's the meta-analysis of that data, that you don't need to change your HME every day. For the same patient, you just use it basically until it gets soiled or it looks kind of nasty and you just can't tolerate looking at that anymore. But 3 days easily for every HME, perhaps longer.
Hey, Rich.
Now
Mike.
Yep, Mike.
I don't want you to go on until this question. We answer this question. It's
okay.
A good one, I think. Do you recommend HMEs that filter as well as humidify?
My own, in everyday use, I'm going to say that I think the filter doesn't really do much. I don't think it saves the patient from anything in the circuit because there's nothing in the circuit, and the filters going into the back of the ventilator are have a much lower micron size than the filters in the circuit. If you feel you want to use them, I think that's fine. They cost more, and they're more likely to become occluded. I'm going to show you some pictures, and things that we don't know are let's say we have a bunch of people with SARS, do we want to have do we want to have filters in the circuits? Do we want to have HEPA filters? And do we want them at the airway, or do we want them on the expiratory limb of the circuit, or where do we want to put them? But my own everyday practice is not to use a filter in the HME. The one I showed you does not have a filter in it. If that's what you're comfortable with, I think that's fine. I don't think there's anything wrong with it. I just don't want you to feel like for some reason it allows you any extra protection, because I'm not sure that it does. Is that fair?
Great answer.
And I'll go back. HMEs can't be used for everybody. Now, it may be in a mass casualty situation we have to use them for everybody, but they do add dead space. They don't, the patient still ends up losing water from the respiratory tract. The resistance of them can increase. You have to take them out of line to give an aerosol, and they can be occluded. So the disgusting picture after lunch for today is this is one of the HMEs just to show you that they can become occluded. I took this on a patient a couple of years ago. I thought I'd better take a picture to show people that it really is an issue. And Dean showed that if you look at HMEs versus heated humidifiers, that your risk of having a occluded endotracheal tube from secretions is about 3 or 4 times greater if you use an HME versus a heated humidifier. I think everybody will probably use closed circuit sectioning. It seems now that it's cheaper and we only change it between patients, it clearly is the way to go and doesn't seem to affect the VAP rate. And I would change it like I do the circuit in between patients when it doesn't work anymore, or when it's so disgusting you really find it offensive to look at. Now, the aerosol producing procedures, and I think this is important, and we think about getting infected from our patients, and I know there are a lot of people running around and say, oh, you got to be careful of the patients on the ventilators. I'm not worried about the patients on the ventilators as much as I'm worried about the patients who aren't intubated, the people who can cough and sneeze and blow aerosols around the room, just like we worry about patients who in the old days with TB. So what are the things that cause aerosols to be produced? One of them is the actual act of intubation, while you're putting the laryngoscope in and having the patient cough and gag and blow things into the room. During aerosol therapy, obviously, when you're giving a handheld nebulizer by mouth, during suctioning, during open suctioning, and when the patients are coughing. And I think if you're in the point where you think you have a contaminant, a contagion, you ought to avoid these things, because we don't want to get people, our own staff, infected. And I think it's important, no matter what you do, that you wear personal protective equipment and wear it properly. Non-invasive ventilation we've shown is great for COPD. It does great things reducing mortality, and it may be helpful if you have some small local events, but in a mass casualty situation, I think we should avoid non-invasive ventilation for the following reasons. Studies show that in order for it to be successful, the therapist needs to spend 1 or 2 hours at the beginning getting the patient used to the mask and doing the fitting and comfort for successful implementation. If it's mass casualty care, we will not have the luxury of that time, and that's very important. And the other thing is the time to need to do a bunch of emergent intubations is also not in the space of a mass casualty event, and we don't want to spread the contagion. And this is data from scales from emerging infectious diseases. Shows you the number of healthcare workers in Canada who developed SARS. And what you see is the longer time you were in the room, which comes down on the left, the more likely it is you were to get SARS. Now, the numbers are very small, and it's kind of misleading, but your odds ratio of being in there more than 4 hours versus less than 10 minutes was 24 times greater to develop the virus yourself. And there were some respiratory therapists who became sick with SARS in Canada because they didn't know it was a contagion until it was too late. Now, the nurses, their risk of acquiring SARS also was based on their use of personal protective equipment, and this is another article from that same journal, and looks at who used in gowns, gloves, and their N95 mask consistently or inconsistently, and you can see, if you used a surgical mask instead of an N95 mask, you're a lot more likely to end up getting the infection. So it's important to use the right equipment. And having the right equipment is critical, but using it is critical too. And if you see here, this is from the CDC, right from their website, and it shows you how to do this stuff. And one of the key things I learned from this whole issue is on the bottom here, and that's that you see the person putting on their gloves and then taking off their gloves, putting on their goggles, taking things off, then they take off their gown, pull off their gloves, and then the first thing they did is reached up and grabbed the front of their mask to pull it off their face, which I know I've done with a regular surgical mask 1,000 times. That's where the contamination is, and that's something you have to avoid. So when you see that picture there, you take it off from the rear. Don't grasp the front of the mouth, the front of the mask. That's where you've been breathing in and out, and that's where the majority of any contaminant would be. And this kind of goes to the question Mike asked, the filtering inspired or expired gas. Both of these ventilators draw in air from the room. You can filter the gas going in the ventilator or leaving the ventilator. You may place a filter at the HME to both prevent contamination of the patient and the environment, realizing that that's never been shown to actually be an issue. You might put filter on the expiratory side, and some of the guys from Canada who were in the SARS epidemic told me they were glad to have, I think they were using mostly 7200s that had the heated expiratory filters, and they felt that that improved their safety. Although I believe them, but my reading of the literature doesn't suggest that that's ever been proven. This just shows you. This is the Impact 754 on the far left. You see that's the filter going into the inlet of the machine, and you can in Iraq this is important because it keeps the sand out of the ventilator and out of the patient from the environment. The other position is to put it on top of the ventilator. That will protect any gas from the room going to the patient, but won't protect the ventilator. And then, of course, you can have an HME right at the airway that does have a filter to try to filter gas that way. You can put filters in the expiratory limb, but remember they can become full of water. It doesn't matter whose you use. Eventually they'll get soaked or they'll fill with water. And if you're using them, you have to look for signs of expiratory resistance. And with the 754, that would be that graphic I have here, the needle slowly falling down to airway pressure, or in the 754, a prolonged expiratory or inspiratory pressure as the pressure comes down from the inspiratory pressure. So I know I'm getting close on time. So my summary of that is that a mass casualty event will not only task the equipment, which the nice people from CDC and SNS are trying to help us with, but also personnel. And our use of protocols for safety for our patients and ourselves will be important. Now's the time to start thinking about this, not when it happens. Respiratory therapists, this is our time to shine. This is what we know more so than anybody else, the unique aspects of each of these ventilators and how to use them properly. And AARC has partnered with people, with HHS, about doing for these ventilators, and we've already done one training, and I hope that we'll do some more. So I think that's very important. And unfortunately, my little screen here doesn't let me see the questions anybody's asking, but I'll be glad to answer them if they have any.
I got it, Rich. We've got one question. Does the impact or LP10 use any additional gas other than that being delivered to the patient, i.e. bias flow?
No, neither one of them do. They both are very gas efficient. Just about 99% of the gas that goes into them goes to the patient. I think that's one of the reasons that these devices were picked, is that they have a low gas consumption.
And I know you talked about patients being infectious and that sort of thing. One other question is when is an infected patient most likely to infect a caregiver?
Well, I think it depends on what they're infected with. I mean, one of the things, maybe, I don't know if Eileen's still there, she wants to comment about this, but, SARS is very contagious. One of the interesting things is if you have a patient with inhalational anthrax, they virtually have no ability to transfer it to you. So that's something we hope to get some more information out about, especially to therapists, to know, obviously the whole avian flu process is a big concern, but so far it's been very difficult to spread from one person to another, and that the lethality, I guess, is that a word? The lethality of it is that it affects the alveolar lining, which is why patients get so sick and have bad respiratory failure. But the fact that it affects the alveolar lining also is one of the reasons that apparently it is very difficult to spread from one person to another. And people who understand viruses tell me that a virus is always trying to become easier to spread because it wants to survive, but generally as it becomes easier to spread, it becomes less lethal. And I'm kind of hoping that that's going to be the issue.
Well, Rich, both you and Eileen, first of all, on behalf of the AARC, I want to express our appreciation for both of you and for the listening audience on behalf of, again, the AARC. You can't imagine the role that Rich Branson has played in helping the AARC react to this, hopefully a national emergency that will not ever occur. And with that, both Rich and Eileen, I don't know if Eileen can still hear me or not. I think she can. If you have any parting comments, now take that opportunity, and then I'll close the show.
I didn't have any.
Go ahead, Eileen.
I'm sorry. I didn't have any further comments, but certainly if you all have my information, I saw that there were a couple of other questions that kept popping up there. Please feel free to email me if you have something in particular that you're, as of concern, or you have questions about the vents or the equipment and stuff that's coming.
This is Rich. I just will tell the respiratory therapists again. I mean, we've spent a lifetime trying to show our value in the hospital and in home care and elsewhere. And, and apologies to nurses who are listening, and Eileen, and my mother's a nurse. But, these days, what a nurse learns in nursing school about mechanical ventilation encompasses less than about 4 hours. And there's nothing wrong with that. They just have, their training is in a different area. And, in order to be successful in this situation, respiratory therapists are going to have to be involved in the planning, the purchase of ventilators, the training of people. I mean, I really think this is the time for the profession to really show how important you can be, or of course, unfortunately, how important you may not be if you don't become involved at the highest levels about this. So I think it's a real mandate for the profession to step forward and use and show its expertise.
Well, Rich, my final comment, again, Eileen, Rich, thank you very much. My final comment, Rich, is I'm also a nurse, and I am fully aware of what they're taught in school, and it certainly is a different level. Thanks again, both of you. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hours. If you are watching this program as an archive, this concludes our presentation.